Thank you, everyone. How's everyone doing? Are you awake? You got your rollerblades on, because we're going to fly through some very interesting information. I am a fast talker, and I apologize about that. If you're interested in anything that I have to say afterwards, or want any other information about myself, I have some of my cards at Plants Not Pills located over next door. So today I want to talk about the science and physiology of the endocannabinoid system. First and foremost, how many people in this room have heard of or know of the endocannabinoid system? Okay, that's sad. How many people in this room know about the thyroid? Y'all know it? Did you guys study it in medical school? Right? When they talked about it, did you pay attention? Okay. What defines a system? Well, you have to have ligands, you have to have receptors, and you have to have enzymes, correct? Okay, so the endocannabinoid has all three, yet you're ignoring it. You want to tell me why? Do you want to tell me why, as you call yourself a scientist, that you're not paying attention to a system that we've discovered in the human body, and you're refusing to help people even if we can take advantage of that? Isn't our job as physicians to help people and make them feel better? That is what this can do. And this can change lives. It has changed lives. It's changed lives for all of my patients. So I'm going to tell you a little bit about myself. I am a board-certified anesthesiologist. I practiced anesthesia for a number of years, and then I intermittently was doing interventional pain management, and I continued to do pain management interventionally and with the nasty drugs. And I was at a conference, and I heard a very familiar voice call me. I was at the Florida Society of Interventional Pain Practitioners, and I'm walking into the conference, and I hear someone call me, and he's actually in the back of the room right now, and it was a familiar voice, and I hadn't heard in a while, and I go over, and I go, "Hey, JD, what's going on?" And he's at a booth, and his booth says, "The Green Solution." I said, "What's this?" He goes, "Well, it's medical marijuana. We can do it in Florida now." I said, "Really?" So instead of going to most of the conference like most people do, I was a very bad doctor, and I stood by the booth because I wanted to learn what this was all about. Because if, in fact, there can be some benefit from marijuana, I wanted to learn about it and learn what I could do. Because my job, as I view myself as a physiologist and pharmacologist, being an anesthesiologist, is to learn, study, and apply myself. And if I don't do that, I am not paying attention to what I signed up for as a physician. So I decided to start studying it, and I studied the crap out of it. I learned a lot about it. It was amazing to me, and it's going to be amazing to you. And I decided I'm going to go visit a growth facility, because if I'm going to order something and prescribe something for some people, I want to see it, smell it, maybe taste it, and learn all about it. And that's what I did. And I delved very deeply into it. And then I was invited to speak to the Senate Health Subcommittee in Florida in 2016 after they had passed the amendment asking my opinion on what was going on. My opinion, fortunately, was I was very, as I am now, I'm going to tell you my opinion. My opinion was there were several things that they were doing that were incorrect, that they needed to correct, and fortunately they corrected some of them. They did say that you had to wait 90 days at the time after you saw a qualified physician to get your medication. And at that time, you were able to get it for muscle spasms. I think they messed up, and they meant, when they said muscle spasms, MS, they meant multiple sclerosis. But they put muscle spasms in. They could do cancer, seizures, and terminal illness. Now, if you had any of those conditions, you would see a qualified physician. You'd have to wait 90 days because you had to establish yourself as a patient, and then you could apply and get your medication. So when I went up there, I told them, well, last week I had 4 of my patients die, okay? Because they came to see me, they had a terminal illness, and I had to tell them I couldn't give it to you because some legislators up there decided that you had to wait 90 days, even though I could prove that you had that illness by just asking your referring physician for your medical records. But that's not good enough for you. Okay? For some reason, there's a big stigma against this. You guys need to lose it, okay? That's my website. I also have another website. If anyone here is interested in learning how to do this, it's called thctrainer.com. And if you want to learn and come and shadow me and learn about medical marijuana, you're more than welcome in my office. Also on my website, the Herbal Clinic MD, there are patient videos where I do a unique approach where I show people all about marijuana by interviewing patients and knowing how to manipulate the strain so they understand what's going on. And that password for those videos is THCMD patient. You might want to watch it because I think it's a very unique way of approaching your patient and having them well educated before they come into your office so that they know what they're dealing with. Which is the most important thing, is that you want to educate your patient. Because if you as a physician do not do that, you are not doing your job. So that's all about that I discussed. And let's get into it. So what happened? Well, in November we passed Amendment 2. Amendment 2 came and went, and by the way, it passed by 71%, more than any amendment in the history of the United States for anything. Yet our government is really putting the kibosh on allowing us to do what we're supposed to do. I mean the Florida state government. So it expanded our medical conditions to include PTSD, which by the way is my favorite, because anyone suffering from anxiety, and any doctors know that your patients suffer from anxiety, has had to have had a trauma to have anxiety. That's a fact. Okay, the only way the limbic system gets fired is if you have a traumatic event and it goes to your midbrain and it fires in the hardwires like a hard computer. And if you ask your patients, which most doctors don't do, how was your childhood? How was growing up? Were you beaten up? Were you abused? Were you made fun of? And guess what? You get yes, 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 yes. And you have anxiety. You have PTSD. It's just that you didn't take the time to inform the patient that that's what's going on, and neither did the psychologist or psychiatrist, because I pick it up on almost every single patient. And that's the prime one that I use, because that's the prime one that I can affect. And if I can affect your life and make you feel better and make your quality of life better, am I not doing my job as a physician? I am. And at the same time, I get you off of all those crappy drugs that you're on, which we'll go into later. Chronic non-malignant pain. Well, they put that up there and I say, yay, great. By definition, chronic pain is pain that exists for greater than 90 days if you've had an illness, correct? Well, not in the Florida state legislature. What they meant by chronic non-malignant pain was you have to have chronic pain from a qualified condition that exists beyond 90 days. Well, that doesn't make any sense because you already have the qualified condition. So they kind of made it look good, but they didn't. Parkinson's disease, multiple sclerosis, HIV/AIDS, glaucoma, ALS, Crohn's, severe debilitating medical conditions, and I forgot one, sorry, cancer. Okay? And we're going to get into that. So what do you do when you talk about cannabis to your patients? First and foremost, I hope you get educated and you understand all about the plant. I don't want to go into it, but basically, real quick, there's two different strains, sativa and indica. Sativa plant is your uplifter, make you feel good, make you concentrate, make you think better, expand your mind. It's the Einstein, okay, which he used. And there's indica. And indica is the strain that's your relaxing in the couch, your chill out, your anti-anxiety. So sativa can work on your depression, and then indica can work on your anxiety. So you want to find who qualifies, and then you do this. You have to alleviate fears because your government has told you since 1921 that it's bad for you. Do you know why it started in 1921? Because the same company that tried to get rid of it, it's trying to get back into the industry, is Bayer Aspirin. Because Bayer Aspirin went to all the doctors and told them that we don't want you guys using this, we have a better anti-inflammatory, because cannabis is an awesome anti-inflammatory. And as a result, they worked with the different medical groups, and they got the backside from the physicians. And then the Marijuana Tax Act came out. Okay, so that's the history. And by the way, since 5000 BC, it's been used in every single civilization for medicinal purposes, every single one. So you think over the last 100 years we're better than the last 5,000? Come on. So now I do this. I discuss the endocannabinoid system in detail. I go through it with the patient. In fact, I do it in advance. They have to watch the videos and they have to read my articles that I've written about it so they understand it. And they come in with a bit of understanding about what that system is. The key is to discuss this, the benefits of THC to CBD ratio of 1:1. And we're going to get into it, but basically, here's the deal. The plant has 482 different products in it, of which we know very little about most of them. But the main ones, THC and CBD cannabidiol, are the main ones that we utilize for medical effects. Well, if you keep, CBD blocks the psychoactive center from THC. If you keep the ratio of THC to CBD exactly the same, you cannot get high or feel good, which I'm not so sure as a physician why it's so bad to make somebody feel good. But if you keep it at 1-to-1, you do not get any psychoactivity. Okay, so patients that come and say, well, I don't want to be high, even though they're on opium and benzodiazepines all the time, you just tell them, well, we can just do a 1-to-1 ratio, and by the way, this is going to give you the most medicinal results for the patient anyways. So I really push and emphasize that. And then you have to discuss what's called the entourage effect. And what that is you have to have all that which the plant has to offer to benefit the patient. You can't extract just THC and use it. That's bad. That's Marinol. That's also those drugs on the street, K2 and Spice, that permanently bind to the receptor and cause problems. The receptor is not meant to be bound to permanently. Okay? But you cannot extract just CBD and get the effect. You need it all. You need the terpenes. We don't know why. We're at the tip of the iceberg, but at some point we're going to find out that there might be terpenoid receptors. We don't know yet. But we do know that to get the best medical result, you need all that which the plant has to offer. And then this is what I do in pain. I get everyone off the big pharma crap that they're on. You ever look on your EMRs and you see all their medical things and you see, remember all those little red dots with the exclamation points? And you guys keep on ordering stuff? Guess what? Those are drug-drug interactions happening inside their body that are not good for them. Yet you're giving them those drugs every single day. And by the way, how many people in the US die from narcotics every single day? 91. That's 2015, and I'm sure it's a lot higher than that if you include heroin, which is what everyone else is using right now because they can't afford the opioids or they can't get them from their physician. How many people in the history of the world have died from cannabis? Come on, guys, 0. And I'll tell you why later on. All right, so the endocannabinoid system, this is really, really cool. This is the only system where you have your precursors produced in the postsynaptic membrane, and you have your ligands then travel to the presynaptic membrane where they bind to their receptors, and then they exert their influence. Well, the ones in the brain is called an endamide. There's another one in the brain called 2-AG, and in the periphery, 2-AG, and also there's PEA. So an endamide, which means bliss, is primarily in the brain, binds to those receptors, and when it gets to the CB1 receptors, it either turns up or turns down the release of the neurotransmitters. It maintains a tone. It's called the endocannabinoid tone. And we have discovered that a lot of people have multiple disease states have an endocannabinoid deficiency. And over time, as you age and you produce less endocannabinoids, you can't bind the receptors and you lose the ability to bind or control those neurotransmitters. Okay? And there are articles and articles being written about endocannabinoid deficiency. So humans produce endocannabinoids. The main ones are anandamide in the brain and 2-AG in the brain and in the body. Anandamide primarily binds to CB1 receptors. 2-AG primarily binds to CB2 receptors in the brain and throughout the body. You have more cannabinoid receptors in the brain than anything else. Epinephrine, norepinephrine, serotonin, dopamine, tryptophan, you name it, this one has more. Endocannabinoids function as neuromodulators and maintain a cannabinoid tone. You ever meet people in their 90s who are happy and look good and are going along, and you're wondering, what the heck's going on with this guy? Bet you anything, his endocannabinoid tone is humming. You met 20 and 30-year-olds who are miserable with multiple diseases, they have no endocannabinoids. And it's dietary related because it comes from arachidonic acid, okay? So these people eating or avoiding healthy fats can't produce it. Okay, there's the way it goes. So when you stimulate the receptors, it controls the release of the neurotransmitters in the brain, and in the brain, the cannabinoid receptors can either excite or inhibit nerve function. You want to ignore that? I don't. Okay, so here's the system. So we have anandamide, which is your primary ligand. It binds to the CB1 receptors, and in the brain, it binds to numerous areas. The one area in the brain that does not have cannabinoid receptors is the breathing center. It's impossible to overdose, guys. Yet you have tons of receptors in your breathing center for opioids and benzodiazepines, and that's why when you combine those two, you're killing 91 people a day. So in the CNS, it binds to the hippocampus for memory, the hypothalamus for appetite and other things. It binds to the hypothalamic pituitary adrenal axis and lowers the cortisol levels. That's a good thing. And by the way, it's an anti-inflammatory and it's an antioxidant. And by the way, your government does have the patent on cannabis that it got in 1998, and it says in the patent that it's neuroprotective and an antioxidant. Yet your same government schedules it as a Schedule 1 drug. That means it has no medicinal value and we cannot do research on it. So tell your government to reclassify it as Schedule 1B. Allow the Bs to be Schedule 1 drugs that which we can do research on. Do not allow your government to move it down into a schedule that we can then allow them to further control, because then they'll, as you know, make it very difficult for us to give to patients. That's just my 2 cents worth on all these people that say legalize it. Just let the states do what they want to do. Let the government allow research. So then it binds to the limbic system. That's our anxiety. That's the bad boy I love to work on, because every single patient I have has a PTSD or an anxiety. And that's where you help people the most. That's where you improve quality of life. That's where you're life-changing as a physician. That's when I get people coming in to see me, and I'm not lying. They come up, they hug me, the husband, the wife. Guess what? We're having sex again. Our life is better. You improved our quality of life. Nothing makes you feel better as a physician than doing that. As opposed to my past, where I'd be doing injections and putting in spinal cord stimulators, and patients are miserable, they're on their drugs, and their sexual dysfunction because of the drugs. Doesn't make any sense to continue doing that, and it never would help. That's why I'm so passionate about this, and that's why this is all I'm doing now. I'm not doing pain management. I'm getting rid of Medicare, I'm getting rid of insurances, and I'm going to this, because this works. So then, it also binds to the nuclear accumbens, which is your reward and addiction, and most importantly, it binds to your basal ganglia for sleep. Guess what? The first thing everyone says to me, God, I can sleep. I wake up and I feel great. How does the body repair itself? Sleep. How does the mind repair itself? Sleep. How many people come in complaining about lack of sleep? All your patients. Because of all the crap that you have them on, they can't sleep, and all their other medical problems, and all their PTSD, and all their anxieties, and they can't sleep, and they can't repair themselves, and it's a vicious cycle, and that's why they continue to circle the drain. But you can make people feel better, and there's a better way to do it, and you can do it with cannabis. So it also goes to the nociceptive centers for pain, and the hypothalamic pituitary adrenal axis. The CB1 receptors are also present in the uterus, and by the way, the only way that your embryo can attach to the uterine lining is if an endomide is present. Without an endomide, that cannabinoid, you would not be existing. It binds to the cardiovascular system, the adipose tissue, the GI system, the pancreas, and the liver. Now, the CB2 receptors are present throughout as well. They're in the central nervous system. They are in the microglial cells, which is responsible for inflammation, where you release your cytokines from, and we're going to touch upon that later when we talk about concussions. But it also is in the dorsal root ganglion and in the spinal thalamic tract. In the periphery, this is important, guys, it binds to the mast cells. That's where you release your cytokines. That's your inflammation. It prevents inflammation. It's an anti-inflammatory. It binds to your GI tract all throughout it. You would not believe how Crohn's disease patients do. They do unbelievably well. They get off of all their medications. They no longer are struggling to go find a bathroom, and their lives are no longer miserable. It is the most life-changing thing that you can do for a patient. And it's in your immune system. Macrophages, monocytes, B cells, T cells, thymus, spleen, it's all throughout there. That's why it works on autoimmune disorders, because it maintains the tone. I don't have it up here, but it's also in your bone marrow and in your bones. It affects your osteoclasts and your osteoblasts, and it prevents bony demineralization. So we have our CB1, CB2 receptors. We also have these other receptors, GRP55 and TRPV1. TRPV1 is like your capsaicin. So when you bind to that receptor, you decrease your nociceptive and neuropathic pain pathways. And as a pain practitioner, that's where you can really take advantage, because you can use just CBD alone and affect those pathways and help out those patients. So CB1 has receptors in the brain, modulates the numerous functions. Here we go. These are all the symptoms that we just went through. Systems: peripheral control through CB1, CB2, GI tract, immune system, inflammatory system, spinal cord for pain control. Do I have your attention? Does it sound important? Are you kind of bummed that you're not paying attention to this? I am. I'm bummed that not more doctors are paying attention to this. Now that we know that there's a system, what does the plant do? So we have our phytocannabinoids, which interact with our endocannabinoid system. We have our famous one, THC, which is a very good binder to CB1 and CB2 receptors. We have cannabidiol, which doesn't bind so well to CB1, a little bit better to CB2, but also binds somewhat, or doesn't bind much to, binds very strongly to GRP55 and TRPV1, which is some of the pain pathways. So CBD is very good for that. Now, the other thing is when you take this in, you have this, you can consume it by smoking or by sublingual, and it bypasses the liver. If you take it orally, that's the bad boy. That's what most people like. Why? Because your liver converts it to 11-hydroxy-THC. 11-hydroxy-THC binds 10 times stronger and lasts 10 times longer at the receptors. That's why patients like it. You get longer duration of action, and it works more effectively doing it that way. The only problem is starting them off on that is very difficult because you really want to have them dosed out prior to putting them on taking it orally. You want to dose them sublingually or through vaporizers till you figure out the correct dose for the patient. So what does CBD do? CBD boosts your endocannabinoid system by blocking fatty acid amide hydrolase from metabolizing your cannabinoids, by boosting your release of 2-AG, and by preventing the presynaptic membrane from resorbing the cannabinoid. Okay, so CBD boosts the effect. So everyone talks, I'm just going to use CBD and it works for me. CBD alone works for me. It might. If your endocannabinoids are pretty good, then we boost that, just like a serotonin reuptake inhibitor. That's good, and it can work. And in those situations, it works. When it doesn't work, they have a poor endocannabinoid tone, and so we need to add in THC and get the binding. But if you're worried about too much psychoactivity in the patient, then you want to have the CBD and THC at 1-to-1 ratios. And there are ways to do that, okay? So THC binds CB1, CB2, CBD binds CB2 and receptors, and it prevents the metabolism. We need our terpenes. We need those. We don't know why, but it's called the entourage effect. We have the 11-hydroxy-THC, which binds very strong, and CBD binds to the TRPV1 and GRPV55s. Okay, now let's talk about this. So that's the system, and that's what works. That's how it works, and I know it's a lot of stuff, and there's a lot more to it than what I'm presenting here, and I'm trying to get through a tremendous amount of information, but I want to touch on some topics that are dear to me and I believe affect lives positively, and that's PTSD. Not only our military people, but every single person has PTSD. I'm anxious. If you're anxious, you have PTSD, because you had to have a trauma to stimulate your limbic system. Don't forget that when you're talking to your patients. So you can differentiate between a standard PTSD, like I went to war or I had an accident and that created it. But there's also this underlying thing called cumulative PTSD, the little hits when you're in school. This person bullied me. My mom made fun of me. My dad beat me. You have no idea what I've heard in the office in the last week by simply asking, how was your childhood? One person told me, at age 6, I was kidnapped. At age 10, I saw my stepfather kill my stepmother. And at age 14, my drunk mother used to beat the crap out of me. One person, but I'm not anxious. Or I'm sorry, I don't have PTSD because no one else has told me that. Well, I'm telling you that you have it, okay? So you want to differentiate your cumulative PTSDs from numerous relative events that were stressful throughout the life, okay? All these things happen. They happen like you wouldn't believe here in the United States. And we need to figure out a way to help these people, and that's what cannabis does. Any anxiety can be traced to some traumatic event or events, and traditional PTSD is thought as one major event as the trigger, but that's really not what really exists out there. So what do you do with these people? Well, I learned in talking to our vets that there's several things that they go through. They go through mixed emotions throughout the day, and when I mapped it out with them, what they start off with is depression in the morning, mixed emotions throughout the day, and severe anxiety at night with the inability to sleep. So what do? You map that out with your strains. You give them sativa in the morning, which is an antidepressant. You give them a hybrid in the middle of the day, which is an antidepressant and anti-anxiety. And then you give them indica at night, which is a chill-outer and a relaxer, allows them to sleep and not have their nightmares anymore. Then they come back to you 4 weeks later, and they're like, oh, my God, what have you done to me? I'm normal. I feel great. My wife doesn't want to leave me. My kids are happy. This is the stuff that happens. I'm not making this up because I have over 700 patients in the registry now. Okay, I've been doing this for over a year and a half, and I've converted almost every pain patient into this. So how do you usually do this? I usually dose with a sublingual dosing because that way sublingual is great. And the key in marijuana is start low and go slow. You start with a very small amount, and you have them titrated up. Every 4 days, you increase by 50%. Rinse, lather, repeat. Rinse, lather, repeat. That's why I'm bald, okay? You start with a small amount, you add a little bit, and add a little bit. You never start with too much, because then you're going to have problems. I also recommend a vaporizer. I call it vape to escape, because anxious people know when they're going to go somewhere and it's going to really suck for them and they don't want to go do that. So you give them a vaporizer of indica, you have them take a hit or two of it before they go into that event, and you prevent them from having a bad reaction at that time. You can also use that at night to help them go to sleep. Typically, there's no need for greater than 5 milligrams 3 times a day, but it varies upon the patient's endocannabinoid tone. And along those lines, how do you know how to dose a patient? It's very difficult, because really it's all dependent upon your cytochrome P450 enzymatic makeup. And everyone's genetic makeup is different, so we don't know. But I typically ask, are you really sensitive to medicines? Because if you are, it's not going to take a lot. Or, oh my God, it takes me a lot. Well, you're probably going to end up having to take quite a bit to get the effect. And that's all driven by your cytochrome P450 enzymatic genes, okay? Okay, got hit, take a hit. That's my message to the NFL, and I'm writing an article about that, and it's going to be published next month. It's concussions. This is amazing. 3 things happen when we're concussed. You get a massive release of glutamate, you get significant vasoconstriction, and you get a delayed inflammatory release of cytokines by the microglial cells. Guess what, guys? Cannabis stops it all, dead in its tracks. If someone is concussed and they take a hit or have cannabis on board, they do not get post-concussion syndrome. That's fascinating. Why are we fighting that ability to help people and get them out of a concussed state? Okay, so 3 main events occur. We went through that. Hours after that injury, those microglial cells are releasing those inflammatory products. CB2, those are the CB2 receptors, and 2AG binds to those and prevents that release. So it stops all of those. Okay, so people who were in an accident and had cannabis on board, they studied them. It was a big study. And they found out that only 2.9% of those who had cannabis on board perished from their traumatic brain injury, whereas almost 4-fold, 11.8%, died if they didn't have cannabis on board. It's pretty interesting stuff. Okay, here's my area, chronic pain. I've already gone over where all those receptors are. They're in the periphery. Remember, the nerves go to the skin. The skin has receptors. We can use cannabis on the skin for neuropathic pain. We can also use it orally, and it's going to affect the spinothalamic tract, the dorsal root ganglion, and the thalamus and the cortex, and it works on all types of chronic pain. I've used it for all of them, and it works magically on them. And by the way, it works on almost everything. You have patients with dysfunctional bladders, dysfunctional GI tracts. It works on that, because there are receptors there, okay? And it's going to balance them out. And those are the things that I learned because people tell me, oh, by the way, my bowels are better. My bladder's better. I used to have a spastic bladder. I no longer have that. So it does work that. And here's the key thing. I get people off of narcotics. I get them off of benzodiazepines. It's easy. It's very quick to wean them off, as opposed to when you normally try to wean someone, it takes forever, because it blocks that withdrawal symptoms, and they feel better, and they don't really want the narcotics anymore or their benzodiazepines. So that is a big win. I get them off of alcohol too. They say, yeah, I don't want to drink anymore because I'm happy. Okay, people are drinking because they're depressed, and alcohol is the worst thing you can do. And by the way, cannabis is not the gateway drug. Do you know what is? You guys are quiet. Alcohol has been proven. That is the gateway drug. Do you know what cannabis is? It's the exit drug. It allows me to exit you off of all those drugs that you are taking. All right, cancer. 5 things that cannabis does to cancer. Tumor cells have cannabinoid receptors. So it induces apoptosis, cell death. It decreases hemangiogenesis by decreasing the release of angiogenic growth factors. It decreases phagocytosis inside the cell when it tries to survive. It decreases metastasis, and it decreases the little sticky stuff that the cell membranes have when they metastasize to stick to your normal cells. Okay? And I have seen patients with prostate cancer go from PSA levels of 4 to 0.137 and elimination of their tumors in 6 weeks by using cannabis alone. I've had 2 of those. Okay, so don't tell me it doesn't work. And then the oncologists say, well, we just don't understand this. Well, how about open your eyes and understand that there's a system that does work, and we can take advantage of that. Okay, so it also treats the cancer therapy-related issues, which are very huge and very troublesome to a lot of the patients. Seizures, you use on seizures, you use very low THC, high CBD. It seems to work much better. One of the things is that it kind of raises your anti-seizure medication levels a little bit, so you kind of have to watch that. That might be the belief by which it works. However, there has been one study that showed 84% reduction in seizure frequency, 11% seizure freedom, 42% had reduction of greater than 80% of seizures, and 32% had reduction of 60% of seizures. But it's not the sole medication that you need to use. So you can use it. It's Charlotte's Web, very low THC, high CBD, seems to work extremely well for these patients. Crohn's disease, you have CBD receptors throughout the GI tract. It's an anti-inflammatory, so it's going to work that way. In addition, it decreases the release of epinephrine at the nerve terminal towards the colon to decrease the spasticity in the movement. It works great in irritable bowel syndrome, Crohn's syndrome, any gut syndrome. It works great on. And by the way, most of my patients who get better also tell me, oh, I'm off my omeprazole, which is a horrible drug. Okay, look it up. And by the way, have you looked up the side effects of aspirin? Google it. It's 12 pages long. How many people in the U.S. die every year from Tylenol? 100. That might not seem like a lot. It's 100 lives because 0 people die from cannabis. So think about what you're giving people. Okay, Parkinson's disease. You have CB2 receptors that are believed to be upregulated and in the disease state, and binding of the CB2 helps control the symptoms. It works like magic. Very little amount needed. Usually it's just the high CBD, low THC that works very well. And for some reason with Parkinson's disease, it's a small amount. And I've seen people going from like this to coming in and saying, look at me, doc, I'm great. And they love it, and they get off of their anti-Parkinson medications. So you have to titrate to effect. Multiple sclerosis does best with the 1-to-1 THC to CBD ratio. For some reason, this is the one that's a magic on, and also cancer. But you need a 1-to-1 THC ratio. It is neuroprotective, slows the disease progression and disease onset of symptoms. Okay? I use sublingual and a vaporizer in combination if the patient suffers from intermittent acute problems. I map it all out. I go through extensive evaluation on the patient, on their symptoms, when it happens, and I try to figure out how to time everything for them. But the main thing is this: I empower the patient. We don't, as physicians. We dictate, you're going to take this, do this, do this. Not with cannabis. The world is your oyster. I'm just giving you cups to go into 7-Eleven and fill them up with whatever you want. And you play with it and you figure out what wants. That empowers your patient. Now your patient feels like they're in control, especially your PTSD patients who have no control. These are important little things to do to help people out. HIV and AIDS, typically you titrate towards conditions that need assistance, especially for weight gain, you need high THC, which is more beneficial than high CBD. And for neuropathy, you can use creams. Muscle spasms no longer is really a condition that we use in the state of Florida. Glaucoma, you need chronic levels of cannabis to have an effect on lowering the intraocular pressure. There are cannabinoid receptors there that when bound to, it lowers the IOP. Okay, and then we have, let's see, chronic debilitating illness. This is a thing that the state of Florida put in that is really a pain in the neck. It says, first of all, their consent, if you've ever read it, is a joke. It was plagiarized from something from the U.S. government. And they basically, in the consent, say that there's no significant evidence to support that this disease state can benefit from cannabis. So when you do a chronic debilitating medical illness that's outside the realm of the conditions that the state of Florida has determined, you have to then send them a letter and research that shows evidence that it does support your condition. Yet you tell me that it can't be compared to the other, which you said doesn't work. They talk like this. They make it impossible for us to help. Okay? So for these people, we can ignore that. So chronic cannabis users. A lot of patients use it all the time. If we're using it for medicinal purposes, I highly recommend that you stop the patient from using it for about 5 days so the receptors can externalize. When you use cannabis a lot, your CBD receptors internalize, so you want them to externalize. Okay? However, I do not stop it on my PTSD patients. It's going to make them miserable. I know that they're using street stuff, and I don't care. And the one thing I always tell the patients is, listen, just be honest with me. Tell me what you're doing so I can help you. I'm not a judge. I'm not a jury. I'm here to help you. You will get far more information out of a patient if you do that one simple thing when you first see a patient. My first thing is, this is not your normal doctor-patient relationship. I want you to be open with me. I'm open with you. And if you hang cannabis pictures in your office, you're going to get much better reports on the patient on what drugs outside the office they're taking. Okay, of all things, you need to know what your patients are on. So cannabinoid receptors need to externalize. All right, my most common recommendation is start with drops sublingual 3 times a day. If needed, I add a vaporizer. I start low and I go slow. I typically begin with 5 milligrams 3 times a day, and every 4 days I increase by 50% until the patient gets results. Okay, once they get results, you can stop going up higher. You're just going to waste your money. So no need to increase once you obtain the results. All right, there's different ways to choose your route of administration. If you basically talk to the patient, figure out the chronicity, figure out, how do you want it to be in their body? Do you want it all the time, part of the time, et cetera? It's just about compliance. It's about what the patient prefers, how they want to take the medication. You can do it by vaporizer, tinctures, oral sprays, capsules, creams. Vaporizer is very fast, 30 seconds, easy to use, excellent quick escape, short duration of action, 2 hours. So they're vaping all day long. So it's better off to put them on sublingual titratable doses and have them vape intermittently instead of vaping all day long. Plus, if they're at work, they don't want to be vaping all day long. So I placed it on the tongue for 2 minutes sublingually, 20 minutes onset of action. Usually lasts 6 to 8 hours and extremely easy to titrate. I like that because they can microdose themselves, and that's nice, as opposed to capsules that are set doses. And with different enzymatic systems that people have, it's better off to do that. That's my preferred route. Oral sprays, they're easy to use, 20-minute onset of action. The problem is difficult to titrate. One spray is a certain set amount, so I don't want to do that. Capsules, same thing. You can't, it's easy compliance, long duration of action, but the problem is that maybe 15 milligrams worked, but you had to take your capsule was 25. So you're better off doing the other. Creams are excellent. I've seen skin cancers disappear. I have seen multiple skin problems go away by applying THC cream to the skin lesions. So when you wean opioids and benzodiazepines, 91 people a day died. We already talked about this. Okay, 0 people die from cannabis. I do what's called subtraction by addition. You add cannabis in, and then later on you subtract out. Do not let them confuse themselves to stop their other stuff when they start cannabis. Oh, I felt terrible. I had diarrhea, and I didn't feel like myself. Well, that's called withdrawal from narcotics. So you just tell them, don't stop anything. Just add this in. We'll subtract it out later. So you may be able to wean other medications too. I've been able to get people off of neuroleptics, Lyricas, the gabapentins, all the Crohn's medications. I've been able to get them off of that. Inadvertently, they tell me they stopped all the other stuff, the Tylenols, the aspirins, the omeprazoles, all those things that have all the red dots next to them. 66% substituted cannabis for prescription drugs, 66%. 40% for alcohol, and 26% for illicit drugs. By the way, in the states at which they have legalized it formally, there's a 50% reduction in big pharma utilization. Clearly, big pharma is not happy with me or anyone else involved in this industry. So the side effects, it's directly related to dose, speed of titration, and route of administration. Listen, if you sit around today and you smoke what's on the street and you think it was the same thing that you smoked 40 years ago, you're wrong, because it's about 5 times stronger. So don't take hit after hit after hit, because you're going to get really, really, really psychoactive. That's the reason why in medicine you want to start low and go slow. The smoking can irritate the lung, cause chronic cough and COPD. No, it does not cause cancer. It's an anti-cancer agent, and tobacco has all the carcinogens in it. You do get psychoactive effects. However, they usually lessen over time, and a lot of times, who minds being euphoric? I have no idea. All right, you have your sympathomimetic effects with some vasodilation, conjunctival injection, mild orthostatic hypotension, tachycardia. Clearly, you have to be careful with your elderly patients and your patients with cardiac disease, but you just want to monitor them closely. And anxiety, if you take it too fast, too quick, we already talked about that. Psychotic breaks happen in 4% of people, but basically it's chicken egg. Because a lot of people have psychotic breaks without having THC, and they can't really track one to the other. This is very rare, cannabis hyperemesis syndrome. You need to basically stop using it. You hardly ever see that. So drug interactions, the one thing is Coumadin. Be very careful because it affects the cytochrome P450. So I always tell my patients to monitor the PT-INR, tell their physician about it so that they can watch that and adjust accordingly. But what's the big deal? All you're going to have to do is lower the dose of medication that you really hopefully don't want to be on. So now we're able to perform what's called genetic mapping. We're going to find certain strains fit you, fit you, fit you. You got this problem, you need that strain. That's coming. In about 10 years, you're going to walk in with your genetic screen, and you're going to pick out your strain, and you're going to be taken care of. Mark my words, it's coming. That's my recommendation. My recommendation is that, so we can achieve this. All right. Shoot.
Wendy, will you pass that? Get a box.
I know that was a lot of stuff, but there's just a lot of material here.
Okay, is this on? Great. Philip Hartman, family practice, Kentucky, also acupuncture.
Great.
So completely up for anything integrative, anything evidence-based that's going to help my patients out. To the point that a lot of things that have been receptor-based make perfect sense, like fibrates and fish oil and niacin, vitamins, opioids, I've taken my patients off of when the evidence no longer supports them being on it.
Good.
Where can we find the, not receptor-based, but the clinical trial-based? I know that the NIH kind of ties your hands, believe me. As an acupuncturist, nobody's making billions of dollars off of that either. Took till 2013 for me to get a good multi-center placebo-controlled review article. But where can I find the evidence on that reduction in post-concussive syndrome? Any evidence on preventing or treating cancer?
I think the reality is we don't have a lot of research. Okay, I'm a practitioner that sees results, and I see what your question is and your point. What I would do is I would look to Israel and I look to Canada, where it's fully legalized, and they're doing all the studies, and they're going to publish all those things, and they probably have papers there. I always go into Google and just put in cannabis and concussion, and you'll just see article after article after article start to appear.
And I was doing that as you were talking, trying to cross-reference the cancer one. Everything I found was confounded by concurrent tobacco smoking.
Right.
I can't help but think there are a lot of NFL players that use marijuana, so that might be a pool that we could look at.
They're getting concussed all the time.
Right.
I don't blame them.
Now, what's your thought on the schizophrenia possible link or increased risk with habitual marijuana users?
I do get concerned about that. I do in the family history try to ask about schizophrenia, but I'll tell you this. Most patients that have that family history will tell you that they're taking street marijuana anyways, and I'm like, are you having any problems? No. Yeah. Okay, let's face it. 60, 70, 80% of people are using marijuana. Okay.
Oh yeah, and I also treat heroin abuse in my office.
Yeah,
so
and by the way, I have heroin addicts come to me to get off of heroin and get taken care of with cannabis, and I do it.
Are they not already using it? Because all of mine already are.
They are using it, but see, if you're not using, you're getting high. First of all, it's variable what they're getting, where are they getting it, et cetera, et cetera. So now it's more controlled. You can also upregulate put more CBD in, and instead of having high THC, low CBD. Because on the street stuff, it's very high THC, very low CBD, and you need the cannabinoid to bind to some of those receptors. I didn't touch upon this, but remember, CBD blocks THC at the psychoactive centers, but THC works with CBD at the other receptors to enhance the results. So you do need both in higher percentages to help out with those particular problems.
And this might be an odd question for you, but you clearly have more experience in utilizing marijuana than most of the people I get to talk to.
Right.
I have some patients who have hepatitis C from using their heroin, and they can't quit marijuana long enough to stay off it for a month so they can get their treatment because their insurance won't pay for the treatment while they're on any illegal substance. Have you found anything useful in helping people who maybe need to take a vacation from it?
Well, your options are to go high CBD, low THC. Okay, just put them on a CBD product. Like in this state, our dispensaries have low THC, high CBD. So I could just switch you over and put you on that.
So they test negative for THC.
Well, okay. Oh, you're talking about okay.
Their insurance company won't pay the 80 grand until.
In fact, I spoke last night for this group. They make no THC high CBDs now. Okay, and they will not test positive. Well, in this state, at that 0.3%, or what is it? 0.8% THC, you'll test positive. Okay, so you got to be off it for at least 30 days if you're smoking or using regularly, and you would have to switch them over to something with no THC in it.
Okay,
because,
thanks.
Yep.
Anybody else looking
Anyone
for the box?
else?
You mentioned Big Pharma. How come they haven't exploited this endocannabinoid system and come out with agents that either block receptors or enhance activity?
They have those.
And get, because they've already looking for a buck.
Well, yeah. Okay. Well, here's my thing. Yes, Big Pharma has looked at how do we block fatty acid amide hydrolase, how do we block MAGL, how do we bind receptors, how do we do this? They are manipulating. They do make some synthetic stuff. Okay, I don't use those. I don't. There are some. I can't even remember the Nabilone and some other ones. I can't remember their names. But Big Pharma is starting to get in. But Big Pharma is also getting in on the other side because Bayer Aspirin is now working to take over the marijuana industry. 100 years later. They'll probably do it by 1921, which will be ironic. But yes, Big Pharma is trying to do that. But you know, it's amazing. You're going to spend so much money trying to make something that's like what you have as a plan. It doesn't make a lot of sense. Although we could make sense out of if we eliminate this enzyme, fatty acid amide hydrolase, and we can boost the person's endocannabinoids, we might get a result. But they are looking into those. So
how are your patients getting their product? Are there compounding pharmacies in states where it's legal to come up with the product you're talking about? Because in Boulder, Colorado, if you saw recreational marijuana, you walk into a
no. We have a whole
shop.
system in the state. We have dispensaries, and you have to go to a dispensary. You put in an electronic system, and then they deduct it. But you can't go anywhere to it. There's no pharmacies. By the way, don't ever say marijuana prescription. You can't prescribe an illegal federal drug. It pisses me off. Okay, it's an order. It's a recommendation. And anyone that has a billboard that says, come get your marijuana prescription, run, because they don't even know the first thing about it. Okay?
Thank you. Is there anything being done to be able to quantify what level of THC causes motor impairment? For example, I get pulled over, I have to do a breath test or whatever. You know, with alcohol, we have the 0.08.
Right.
Where do we
There is
stand with
nothing,
THC?
but there's very little about motor impairment with marijuana. People are very, very functional with it. It doesn't affect the cerebellum like alcohol does. Okay, so there's very little. A lot of patients, well, what if I get pulled over? What if that? Well, you know, you have a marijuana card, and quite frankly, you got to be doing something really stupid to be getting pulled over anyway. So I don't personally make it a big deal for the patient. I try to lessen those concerns for the patient because I want to help them get better function. That's my take on it.
For example, in workplace, say if there's an injury and they do a blood test, shows THC.
Well, blood test will, the urine test will, but here's the problem. You don't know when they took it based upon that. Okay, so then they're going to be inappropriately accused. They could have taken it last night. They could have taken it 3 weeks ago. But the urine test is just going to show the metabolite.
So there'll be a whole field for attorneys to.
I'm sure there will be. Good for them. They need it.